I want to start with our next presentation. Dr. David Rosenthal will give his talk. He's going to give it remotely, actually. He's the director, he's a professor at Northwell Health and director of the Transgender Center in Long Island. We're honored to have him speak with us today. His talk is on transgender health literacy and the Transgender Care Center. So Dr. Rosenthal, we're going to remote to him for his talk. Thank you very much.
Thanks so much, Jim. I really appreciate it. I really am very pleased to be with everyone. So I'd like to be able to speak a little bit about the Center for Transgender Care and really kind of discuss some of the work that we're doing. It's fortunate that actually about the same time that Leonid was able to found the Friedman Center, I actually was identifying patients that were identifying as being trans. And I've had an interesting kind of career direction. I'm a clinical immunologist, and as I was doing that, what I found was that became the medical director for the Center for Young Adult, Adolescent, and Pediatric HIV. And in so doing, I started treating young adults with HIV, and then I started working with HIV prevention and began embedding services in an LGBT center. And as I started doing that, I started having patients more and more asking me, where can I get hormones? Where can I get resources? Where can I find trans care in Long Island? Because we have to travel all the way into the city. And although Peter, Peter Meacher and all those folks at Colin Lord are providing great care for things, there was really nothing else that existed at the time. So I wrote a grant and was able to work with the New York State Department of Health, and they were able to fund the launch of our program. And so we launched in July of 2016, and little did I know that Leonid was launching about that same time with the Friedman Center. And so as these two programs came into existence and kind of went on parallel tracks, we eventually kind of merged some of our processes, and then separately we were able to bring in additional resources and be able to kind of cross-utilize resources. So when I founded the program, one of the first things I realized is that, look, I'm a cisgender white kippah wearing guy, and I'm not necessarily a member of the trans community. And so it was very important that we had representation and hire from within the trans community to make sure we're supporting the program, and also to make sure that we're able to reach out to the community and be able to hear their voice. So one of the first things we created was a community advisory board, which includes members of the community which are able to give us input, their feelings, their ideas, their thoughts about what resources are needed and how we can address their needs in Long Island, and make sure that Northwell Health can kind of build those resources. But we also wanted to partner with the Office of Health Equity to work on diversity and health equity issues, community-based organizations that are LGBT communal-based organizations that we're already working with, and we wanted to help people with both insurance and legal services. And so by bringing together all of those different resources together with the service lines that we were focused in at that point, which was psychiatry, medicine, peds, OBGYN, surgery, urology, and otolaryngology, we're able to bring together kind of a family of services to kind of start doing this. And so that's how we were able to get initially Yusheng Su to be able to be involved from pediatric endocrinology. We were able to get Aaron Skolnick available from adult endocrinology. Some of the work resulted in us being able to recruit Dr. Whitehead. And so we're able to bring together different resources that already existed within the health system and then also to build those out. If people want to have families, how do we do family planning? If people want to have routine OBGYN care, how do we make sure that happens? If people are interested in fertility preservation or andrology services, how do we provide those resources? If people are interested in top or bottom surgery, facial feminization surgery, how do we make sure those resources are available? If people want reconstructive urology surgery or need pelvic therapy, how do we make sure that's available? And how do we make sure that people that have HIV that are members of the trans community can get the resources they need? And also people that we can help them prevent HIV transmission, because we know, like Peter spoke about very early on in this conference, that it's really important that we address the fact that so many trans women have HIV in the United States, and we should do everything we can to help them live happy, healthy lives with HIV, but also to help prevent them from getting HIV. Through my work with HIV prevention, I work with quite a few people of many different types and many different socioeconomic groups. And so it's really important that we're able to bring all of these resources together to care for people everywhere. I'm going to go forward to the next slide, I think, as we go forward next. And so the next slide, when it comes up, will show that we really kind of thought about creating the Center for Transgender Care at Northwell Health is encompassing four major arcs. Those four arcs or four major pillars included the medical care, research, education, and infrastructure. And so the work that Leonid Pretsky has done through the Freedmen's Transgender Care Program is really the entire Western region that kind of got built out, and the work that's being done at Lenox Hill with Dr. Bradley and all the other folks that are working there. We're really operationalizing mostly in the central region clinically, and in the eastern region, we're looking to kind of build resources as time comes along. With that, we really need to build the research infrastructure. And so parallel to the work that's been going on, we kind of were able to start building research projects and research questions. I think Jim talked about a couple of those in his work. I know that Dr. Pretsky has been very involved in a number of projects. I've got ongoing projects that we're collaborating with OBGYN, pediatrics, adolescent medicine. We're also working with or developing projects for endocrinology that Dr. Skolnick is leading. We're dealing with some issues with hepatology with Dr. Bernstein. And we're also taking a look at the resources to kind of make sure we can address trans patient needs from a research perspective across the organization. But really, when we're looking at things, it really kind of encompasses also outcomes-based research, clinical research, and also setting new guidelines and services. Because we have a large number of patients, and I've seen about 700 patients since I started doing this that identify in the TGNC community, it's really important that we're able to make sure that we're not only helping them with the clinical care using the guidance we have right now, but building the credentials and building the research so that we can address them over the long term. It's part of what we're doing also is education. And so we spend a lot of time kind of building out educational resources and being able to make sure that the health system has the information they need. This is a perfect example that was put together by the Friedman Center. We had a similar conference through the Long Island-based center last year, and we hold a conference for patients at Hofstra University every year as well. And then in addition to that, I speak on a regular basis to 100 respiratory therapists. What sort of tidal volumes do you need to set in someone based off of their assigned gender at birth and their current gender identity? What are we going to take a look at when we're taking a look at nurses that are pediatric nurse practitioners? We're going to be speaking to school nurses next week, actually, talking to how do we address transgender patients in all of our schools? What kind of resources do we need to look at when we're talking about proper care for individuals when they're undergoing anesthesiology for any purposes? And what needs to be done in the operating room to make sure those resources are being built? So working with North Shore University Hospital, Jared Oliveri, with community relations, with diversity and health equity, we've launched a number of initiatives. And I'd like to be able to share with everyone, and I'll send around the information to Dr. Paretsky after the conference. We've actually just launched a new 1-hour CME initiative that we're able to understand and discuss gender identity and sexual orientation through a learning module that's given CME credits, which is actually a really basic course, but actually gives us some very important information. And it's important for us to be able to say that we've taken that course and we have knowledge in that area, because as people that are treating individuals of the TGNC community, we really need to make sure that we're able to address their needs and take care of them and make sure that we've reached certain amounts of CME in this area and show as a health system that we're doing this across the board. We work extensively with the Expressions Berg. The Berg is the business education resource group. So anyone who's not aware of them can join. That's basically the LGBT employees and allies, and we talk about issues about LGBT health across the health system. And we're working with the CME office and nursing education. But a lot of what we've been doing and focusing on has also been in infrastructure. So we have multiple projects that we've been doing. We've been working with the OCIO, and we'll talk a little about how we rolled out sexual orientation and gender identity across Northwell Health. We've been working with human resources to make sure we have alignment between all of our policies, that our employees can be called the names that they want to be called, that our disability policy aligns with our medical leave policy. But we also want to make sure patients are having great patient experiences. And we've developed a patient experience video that actually was shown by Michael Dowling at one of the senior leadership meetings that really highlights the trans experience. We're working with community relations, diversity, health equity, and then we're also working on kind of supporting additional needs. Although we don't have the funding of an organization like the Freedmans in Long Island, we are being supported by the health system, and so we're continuing looking for additional ways to diversify our funding and make sure that we can continue to provide outstanding resources and as well as address needs of the health system to look where we're going geographically. I'm going to show some of that data next. Next slide, please. So we're going to talk about terminology first. I know this is a little late in this conference to be talking about terminology, but let's kind of jump into it. So next slide. When we take a look at sexual orientation and gender identity, or SOGI, we're really wondering, why have we been talking about all of this? Why is all of this coming up? Why is this suddenly very important? And what really happens is the Federal Register in 2015 put out Health Education Information Technology Guidance. The New York State Department of Health in February of 2019 came up with identifying people and making sure that we're not discriminating based on sex, gender identity or sexual orientation. And we want to make sure that we're able to maintain awards like Diversity Inc. and the LGBT Healthcare Equity Index leadership status, which we certainly do as a health system. Joint Commission has a role in this, but really what this comes down to is that we want to care for our patients. We want to follow the Northwell Health culture of care. We want to make sure we're connecting to our patients, we're aware, we respect them, and we're providing empathy. Next slide, please. So when we're talking about gender, I want people to understand that gender is not necessarily a simple concept. I think we all were taught about boys and girls, and that's all that we probably learned about initially in our experiences. What we really need to remember is that gender is a combination of different concepts. And one thing that you need to think about is gender identity, as Cecilia Gentili, a friend of mine and someone who's active in the trans community in the city, says, gender identity is what's between your ears, not what's between your hips. It's funny, you can laugh, it's okay. I really think that it's important that we remember your gender identity is not the way you look, it's not the way you speak, it's not if you're on hormones, it's not if you had surgery. Your gender identity is how you consider yourself. It's your conception of yourself. And so it's important that we're able to differentiate gender identity from sexual orientation, because sexual orientation is who you're sexually interested in. And there's other concepts of gender, who you're attracted to, how you express your gender, what your anatomical sex is, and all these other concepts of sex and gender. And the fact is that they're not all the same. The perfect example that I give all the time is that I have someone who was assigned female at birth that identifies as male and is interested sexually or romantically in someone who is male. They consider themselves to be a trans guy because they were assigned female at birth and identify as male now, and they're romantically interested in other people that are male, so they consider themselves to be gay. So assigned female at birth, identifies as male, romantically interested in someone who's male, identifies as gay. So gender identity is not the same thing as sexual orientation. Next slide. So gender identity is a sense of oneself as being male or female, feminine, or neither or leaning towards, and it involves social and personal roles, where sexual orientation is your romantic, sexual, and affectionate attraction to others. And when we think about being trans, what we're talking about is your gender identity is transgender. So going back to organic chemistry, I know we're all going to groan and remember the carbon molecules. If you have carbon molecules that are on the same side of the carbon chain, they're in cis formation. If they're in opposite sides of the carbon molecule, they're in transformation. So if your gender assigned at birth is masculine and you identify as feminine, then what you're talking about is as being transgender. And so it's important that we talk about these two different aspects of things and realize where the terms cis and trans come from. Next slide. So when we're identifying trans individuals, just to make sure the terminology is clear, people that were assigned male at birth and identify as a woman currently are trans feminine or trans women. And people that were assigned females at birth but identify as masculine are considered to be trans men or trans masculine currently. But there's two other groups, and I think that Peter actually spoke about this. He spoke about the TGNB community. I usually say the TGNC community, but it's really the same. We're talking about overlap because what we're talking about is the transgender and the gender nonconforming, gender non-binary community. Because what we're looking at is individuals that are not necessarily saying, I'm masculine or I'm feminine. I'm somewhere along the spectrum of masculine or feminine that we see that makes me either gender nonconforming or non-binary. Either I don't see myself as being strictly masculine or strictly feminine, or I don't buy into the whole concept of gender in the same way, and I really don't conform to one gender or the other. So terms that our patients will use are gender queer, gender fluid, gender non-binary, gender non-conforming, all sorts of different terms like this, and we should be aware of those so when we hear it, we know what's going on. Next slide. This is actually a map that I was able to create. I took a look at when I had a group of students identify what their gender identity was. I had them write out in a word what their gender identity was, and then I was able to create this map. So the larger words are people that identified with one terminology, and the smaller words are ones that people identified with other terminology. And I think that we used to think of individuals just as being straight or gay, and the reality is all of these terms are being used. You can see here we have allosexual, we have demisexual, as well as lesbian, bisexual, gay, questioning, queer, pansexual, heterosexual, homosexual, gay. All of these terms are being used, and we need to make sure that we're able to address individuals based on their sexual orientation, whatever that is, all discrete, distinct bends. Next slide. So I already spoke a little about the LGBT education that we've been looking at in the health system. When we're addressing educational and organizational change, we need to make sure we're doing staff education. When a patient walks into our hospitals, what does security say? What does dietary say when they're giving a patient their tray? How do environmental services treat our patients when they're emptying the trash after someone's had a vaginoplasty? How do volunteers interact with our patients? We need to make sure that the undergraduate professional education is being updated because our next generation of physicians and nurses and public health specialists really need to have this cooked into their education. And so I've been able to work with the Hofstra School of Medicine to kind of build out curricular themes in the first and the second year. And we actually just published 2 papers, one of them looking at our first year effective curriculum that I worked on with several other people on this call, including Dr. Pleak and Dr. Block and Dr. Ha. So it's very important that we look at undergraduate professional education, but also graduate medical education. What are we teaching our residents? All of our residents, our plastic surgery residents, our general surgery residents, our anesthesiology residents, our primary care residents in medicine, family practice, pediatrics, OBGYN. What are we teaching our fellows? And how is gender education fitting into the whole concept of making sure that we're addressing the complete diversity and health equity for all of our patients? And then last but not least, we have programs like this. We're able to address higher teaching audiences and CME or CNE courses, have these multi-modular educational resources where we can provide resources in education and provide information for current professionals to help us catch up with what's going on. And it's wonderful that we have 70 or more people that are here at this conference, but our goal is to continue to spread this word because we have hundreds and thousands of physicians at Northwell Health. We need to make sure that all of us have some basic information about the trans community. Next slide. We talked a lot at the very beginning of the talk about how there are multiple different healthcare disparities for the trans community, and we touched briefly on these already, so I'm not going to get into them. But mental health, housing, food, education, substance abuse, domestic partner violence, and HIV are all really important things that we need to address in primary care settings that we're screening for, that we're looking for, and that we're starting to address these issues as well as other social determinants of health that affect the trans community. Next slide. We know that transgender individuals are up to 4 times more likely to live in poverty, and half of transgender workers are repeated to unfairly being denied a job. And 1/3 of transgender individuals are people of color that have incomes of less than $10,000. In addition, there's a lot of individuals that have to have that work as sex workers in order to have survive. And it's really important that we're able to support people and make sure that their health is being taken care of, whatever choices they're making. Next slide. And we need to make sure our healthcare settings are always comfortable and affirming to our patients. This is an old slide from the Williams Institute from 2011, and it showed that approximately 22 to 25% of trans folks were denied healthcare by a provider. We're not seeing these kinds of numbers right now, but we are still seeing people saying, gosh, I don't know how to take care of it, or every one of your problems is associated with your hormones. And the fact is that as providers, we need to make sure that we're not necessarily blaming everything on someone's trans status. Someone can have chest pain and it's not related to their hormones. Someone can have shortness of breath that's not related to their hormones. Someone can have skin issues that's not related to their hormones. Addressing healthcare needs based on how they exist, and not necessarily blaming one's transgender status as being the cause of the healthcare issues. And when that is the issue, we need to make sure we're figuring out the way to address it. A good solution, I actually had a patient that was admitted to a hospital once, patient with cystic fibrosis, presented with chest pain, shortness of breath, difficulty breathing. And they were admitted to the hospital, had an echo, had an EKG, had a CT, and actually a CT of the chest. And after being in the hospital for a day and a half, they ended up calling me in for consultation to talk about what was going on. So I examined the patient, and I found that the patient was wearing a binder underneath their clothes. They were assigned female at birth and identified as male. And so I was able to do a pulmonary exam and listen to their lungs, and I saw the binder immediately. And so I said, "Oh, I see you're wearing a binder. When did you start wearing a binder?" And they said, about 2 days ago. I said, "When were you admitted to the hospital?" And they said, "About a day and a half ago." This is a patient with cystic fibrosis that had decreased muscle tone in their intercostal muscles that was actually having difficulty breathing because the binder that they were wearing was too tight. We were able to fix the problem by upsizing the binder one size. We were able to resolve the chest pain and was able to make the patient feel comfortable and still feel very affirmed. So it's really important that we're not so sensitive to the fact that someone's wearing a binder that we don't talk about what's going on with their health and make sure we're able to address their healthcare needs. This is the challenge for us as healthcare providers. Next slide. So let's talk about some trans-affirming and inclusive practices. And I think Peter talked about some of these. Dr. Mitra spoke about some of these at the very beginning. So let's go on to the next slide. Pronouns matter. It's really important that we make sure that we identify what pronouns we want to use. My pronouns are he and him. When you take a look at your ID badge, if you're interested in having one of these ID badges that say what your pronouns are, they are available through the Expressionsburg. I can have people that are interested contact me, and I can make sure I put you in touch with the Expressionsburg. The other thing you can do is you can use a simple label like this, which I have available. Actually, next slide. I'm sorry. A simple label like this, which you can see that actually has your pronouns. And you can put that on that clear plastic piece of that you put with your name badge that has your title. And that lets everyone know what your pronouns are. Patients have come up to me many times and said, I didn't know you understood how important pronouns were. I'd like to be able to talk to you about mine. And I think that just by wearing your pronouns as a healthcare provider, you open the door to engage in these conversations and let people know that they're being heard. Next slide. So we're going to take a look at sexual orientation and gender identity as a case study for the health system, and we'll go forward, and that's the SOGI program we put in place. Next slide. As people know, in the ambulatory sector, we were able to develop a change which occurred in 2019, where patients that come into our ambulatory practices, in addition to being asked what their gender is on their ID, they're asked what their gender assigned at birth is and what their gender identity is. If those things are consistent with one another, if it's male, 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 or female, 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 then we don't necessarily ask any more specific questions. But if those questions diverge from one another in any way, if you're assigned male at birth and you identify as trans female, or you identify as male, or you identify as gender nonconforming, any of those options, then we're asked what pronouns do you want to use, and what is your name that you would like to be called by? Because it's really important that we're able to address patients not only by their legal name, which is important for documentation, but it is essential that we address patients by the name that they want to go by their current name, not their dead name, even if that hasn't been changed on their insurance, even if it hasn't been changed on their social security card. So we're working on implementing this. It's been fully implemented in the ambulatory sector, and it will be implemented in coming years in the inpatient sector, and it's available in multiple different interfaces. Next slide. The choice that you can see for birth sex are male, female, intersex, or others. Next slide. And the next, we also see for gender identity, the options that are in the system are these. And this aligns with the federal guidelines, but it also is able to make sure that we can capture this information. And what's important is not just that we capture it, but we display it and that we use it. Next slide. So as all patients in the health system, we ask everyone that comes into our hospitals what their race, ethnicity, and preferred language is. We need to normalize the collection of sexual orientation and gender identity across the health system, and we're going to do that because we ask because we care. Next slide and next slide. So you can see here the choices that you can see for gender identity, and next slide again for sexual orientation. Next slide. What we're also going to do is we're going to collect gender and realize that there's going to be some overlap because of what we're looking at. When you say, what is your sex on your identification, or your gender on your identification, that's your photo ID. That's required to make sure it aligns with your insurance purposes and with your photo ID. And that's what we're required to send out for billing information. But your sex assigned at birth is what appears on your initial birth certificate, and your gender identity is how you conceive of yourself. It's what's between your ears. Next slide. So this information is shown up in the ambulatory medical record because of a change that we were able to put through and that we were able to kind of coordinate through the health system, so that you can see that this individual's sex assigned at birth is male and they identify as female and prefer to use female pronouns. And you can see in the vertical toolbar in green here how that information is displayed directly in the medical record. So the information is inputted by Sorian at the front desk in our practices and displayed to the providers in the medical record, as you see right here. Next slide. If you also are using the HIE clinical viewer, let's say you're a radiologist and you don't live in the ambulatory record, you're looking at someone's labs in the system, you can find this information in the HIE clinical viewer here. Next slide, which you can see as you go closer here. The information of preferred name and gender identity is right up there at the top, and the information about gender identity, preferred pronouns, and sexual orientation is all listed directly here as well. Next slide. If you want to click on this little button up here in the corner, you can get the patient access information, and you can also view that information. And the HIE Clinical Viewer is available for all inpatients and outpatients at any time for anyone just logging in with your health system identifications. Next slide. So as we started to collect this data, I was starting to put some information together. I was going to collect about a year of data. I started in March of 2020, and we were a little busy with COVID in 2019. We became a little busy with COVID in 2020, so I'm collecting and kind of working on the data right now. But we're able to see that when I looked at some of the initial patients that we saw, looking just at the first 3 months of data, when we took a look across the entire health system, across the entire ambulatory sector of the reach of Northwell Health, over 500 practices, which is now over 700 practices, we found that there was 0.2% of our population that was transgender, and almost 1% of those that were aged 18 to 24 identified as transgender. This is very similar to the Williams Institute estimation that you can see that individuals that are younger identify as being transgender more than older individuals. Next slide. This is a slightly old map that you can see. It's a geolocalization map that we've created through Tableau using live data that exists, and takes a look where our patients that are transgender are located and living. And so many of them that are identified are living in Nassau County or just over to the Queens border. And we're going to continue to gather this information, but we have individuals up in the Westchester County, obviously in the city, in Queens, and in all of the boroughs. So it's important to realize that people that are identifying as trans that are coming to our health systems in the ambulatory sector are really all over, and it's important to look at the differences that we're seeing by region and make sure that from a planning perspective as a health system, we can make sure that we're addressing the needs of these individuals and creating resources for them that are specialized spoken wheel type of approaches. We have these hubs, and then you have these spokes that go out into the communities available in all of the neighborhoods of the health system. Next slide. So Robin Scott from up in Westchester actually put together this slide for a conference, and I thought it was really well done. It's important we do the low-hanging fruit. It's really easy to ask certain questions. You offer gender-neutral bathrooms. If you have a bathroom in your suite or in your office that just is a bathroom, it's very easy to say all-gender restroom. It doesn't need to say men, women. If it's just one stall, change the signage, make it easy, make it available. Avoid using gendered language, provide reading material in the waiting room when COVID is over that allows for affirming care, and make sure that we promote materials that are inclusive of trans individuals, and we make sure that we're considering trans folks in everything that we do. Next slide. I'm going to spend the last 5 minutes, and I was told to go a little bit longer to kind of adjust the schedule that we have, so I'm going to spend the last 5 minutes talking about HIV prevention and PrEP. As people may be aware, this is actually PrEP Awareness Week. PrEP is a preventative modality where you take one pill once a day to prevent HIV. It's important for lots of individuals, but it's important that we talk about it with our trans patients as well as people. It's important to speak about with anyone who's had gonorrhea, chlamydia, sexually transmitted infections, has multiple partners, or is maybe not practicing safe sex all of the time. So if you want more information about PrEP, you can always go to northwell.edu/PrEP or email me at prep@northwell.edu, and my PrEP team will be happy to kind of help get you information, figure out where the best place is for your patients to go, and get resources for that. So as we go to the next slide, we see that ironically, it may require greater intimacy to discuss sex than to engage in it. And I think that we do that more frequently with our trans patients, especially if we're talking about trans surgeries. But it's important that we engage in a certain level of conversation as I teach the medical students with all of our patients in our primary care settings and our evaluations to make sure we're understanding what's going on and really helping to take care of the patients. I always say I'm not nearly as cute as that guy, but I hope that we always will be able to make sure that we're able to engage in these conversations with our patients so that they can get the right kind of care that they need. Next slide. So HIV prevention, there's two different modalities. One of them is a risk-based modality where you take a medication preventatively because you're at risk of potentially acquiring HIV. The other one is post-exposure prophylaxis. That's event-based. That's like the needle stick exposure for healthcare providers, or that's like if you have an oops moment after you had condomless sex or something else happens, then you have an oops situation or sexual assault. That's a post-exposure prophylaxis. We're all aware of that. You need to start that as quickly as possible, and it's really important that you do that. You need to go to the emergency room, ideally within 2 hours, best within 36 hours, and no later than 72 hours in order to get started on medications for post-exposure. But for individuals that have underlying risk, we need to be able to not only take a look at things as a reactive strategy, but as a proactive plan strategy. So PrEP takes a look at prevention and is able to do this on a risk-based behavior. The corollary for birth control was something you do for like birth control or a long-acting hormone medication like a LARC or an IUD is a risk-based prevention methodology for pregnancy. Whereas an event-based methodology would be something like Plan B. To talk about what Plan A would be, and that's the preventative modality that we're using. Like, next slide. So this is when an uninfected person with HIV engages in some sort of behavior that has risk. They take one pill a day, and it's 99% effective at preventing them becoming infected with HIV. Next slide. Only people who are HIV negative should use PrEP, and we need to make sure that we're following a protocol to make sure we're looking at these things. PrEP does not have to be prescribed by an HIV provider. PrEP should be prescribed by primary care providers. Endocrinologists should be prescribing PrEP. Primary care doctors, less than medicine doctors prescribing PrEP. OBGYN should be prescribing PrEP. It's only 2 medications. It's easier to prescribe than something like an antihypertensive or an anti-diabetic medication. It's very straightforward, and there's training and resources that we can offer to help you make sure you can do that. And if you do want to refer to someone because you don't have the skill or the time to do that, then you can certainly refer to us, and we'll be able to help make sure that those patients get care. But we're also offering teleprep. So it doesn't matter where you live in New York, we can offer PrEP to you through remote healthcare, through telehealth right now. Let's go to the next slide. It's important we talk about sexually transmitted infection screening. The bane of my existence is someone coming in and they say, for example, that they only have bottom sex, that they only use their anus for sex. And so I said, have you been tested for gonorrhea and chlamydia? And he said, sure, I peed into a cup. That's not what we need to do. We need to make sure that we're taking a look at sexually transmitted infections at the sites and locations where people are having sex. So if you use it, I say, you need to check it. We need to make sure we're doing pharyngeal swabs, we're doing urine or cervical or penile swabs, depending on what's going on. I almost always do urine. We need to do anal or rectal swabs as well to look for gonorrhea and chlamydia. If you don't look for it in each of those 3 locations, you will not find it. Syphilis, HIV, and hepatitis B and C testing is important that we do as well on patients that have risk or multiple partners, regardless if they're trans, if they're straight, or if they're lesbian, whatever it is, we need to make sure we're considering this. Next slide. This is actually the first ad campaign that showed LGBT folks that we put together for the health system. I was able to launch it last year as our PrEP campaign. And we're able to kind of get out the word that PrEP is important, PrEP is out there, and PrEP is available, and it offers protection against HIV. And so it's really exciting to kind of see this sort of advertising coming from Northwell Health, because historically we haven't had intimacy between non-heterosexual partners in our public view. And so it's important that we're able to kind of put out these messages and that trans folks and LGBT members feel that we're addressing their needs and can make sure that their healthcare is being addressed. Next slide. I'm going to also share some another link with Dr. Paretsky after the conference. We actually have a brand new channel that we have available, which has some short videos about PrEP. They're patient-facing. They're about 2 minutes, and they're put together by my team that talks about why PrEP is important and how PrEP can help people. It's very plain spoken language. It's very easy to share. So if you're on social media, then please feel free to share with us that way. I am pleased that we did open a brand new site. Even though we opened our program in 2016, in June of 2020, we launched our practice at 410 Lakeville Road in New Hyde Park. Next slide. And you can see some of the pictures of the space that we have, which is really a dedicated trans space that we have. It has 4 exam rooms, 2 mental health offices, 4 doctor's offices, and rooms for trans navigators, data folks, as well as front desk people. And we have many people that align with the community that come. Next slide. And the program is really multi-modular, just like the program that is put together at the Friedman Center. And we use many of the same providers as that go back and forth. But it's important to realize that we've got providers of all sorts that are here. Like Dee exists at the Friedman Center, and that's a shout out for Dee. We have Nova and Sean at our program and our location. And the 3 of them really are your go-to people that will be there to help answer things. Evie answers the phone if you call her office, and she's phenomenal and really able to kind of get resources to patients and make sure that she's able to help you feel comfortable in our setting and provide those resources. And we have all of the other supportive services that really make the program successful. On site, we have endocrinology, psychology, psychiatry, and then the other services in primary care. And we're also offering the other services like endocrinology on site, and other ones are available remotely at nearby practices near us. So with that, I'm going to conclude, and I think I was able to go on for an extra 5 minutes.